स्पीकर है कंसर्ट में मास्टर, उसी का आवाज़ दूसरे को जा रहा है। जब तक वो उसका दूसरे का आवाज़ अलाउ नहीं करता था, कितने का मालूम नहीं, इससे भी टॉप नहीं सीधे उधर का कुछ बजेगा नहीं, डिस्टर्बेंस मुझे ये टॉप है, मुझे यहाँ पे भी बात कर चिल्लाएगा तो भी पकड़ता है। हाँ मैंने वो किए हाँ वो तो फुल अलग है।
Good evening, friends. We welcome you to another of the PG clinics being conducted under the aegis of the IAP Action Plan 2014 and 15. Am I audible? आपको sound आ रहा है? This program, as you know, is brought to us through a scientific grant from the makers of. Without further ado, we start with the clinic straight away. Dr. Anita, please.
My patient, 3.5 years old female child, by birth order, born of third degree consanguineous marriage, Muslim by religion, Sheikh by community, residing at Dharavi, hailing from Bihar, right-handed. She is brought by and informed by father with the chief complaint of erythematous rash 15 days back, fever, cough, breathlessness 10 days back, left-sided focal convulsion 7 days back, and weakness of left side of the body since 7 days. Child was apparently all right 15 days back when she developed erythematous rash over the body, beginning first over the and then spreading to the trunk, which was macular-papular rash, and this rash was associated with coryza, for which the parents have not sought any medical treatment. The rash subsided over a period of 3 to 4 days. Then followed 4 days later, the child developed fever, cough and breathlessness. This fever was of high grade, not associated intermittent in nature, responding temporarily to oral medication. The child was not active during the interfebrile period, associated with cough which was dry, non-spasmodic, non-productive, and not associated with any post-tussive vomiting or any postural variation, and history of breathlessness in the form of increased rate and depth of respiration. For these complaints, patient was admitted at a local hospital where she received IV fluids and medications, and these symptoms were resolving, or symptoms were in the resolving phase. Then followed 3 days later, child had an episode of left-sided focal convulsion in the form of clonic movements of the fingers of left hand, lasting for 2 to 3 minutes, not associated with secondary generalization, not associated with uprolling of eyeballs or frothing at mouth or any bowel bladder incontinence. There was history of query post-ictal drowsiness. And then child had this multiple episodes of convulsions of similar semiology at an interval of 1 to 2 hours throughout the day. And then they were controlled by some IV medications. Following this IV medication, the child had no further episodes of convulsions. And child was then referred to a tertiary hospital, where 3 to 4 hours later, the father noticed, since the last episode of convulsion, father noticed that there was weakness of the left side of the body in the form of, there was no movement of left side of the body, such that child was not even able to move her left upper limb and lower limb at all. This weakness was static over a period of 5 days, and since the last 2 days on admission to the hospital, father noticed there is improvement in the movement of left upper limb in the form of the child is able to move the limb in the plane of the bed, but not able to lift the hands. And on inquiry, father noticed deviation of mouth to the right side during crying. There is no history suggestive of any other cranial nerve involvement in the form of drooling, of decreased hearing, difficulty in swallowing, change in the voice. No history of any bowel bladder involvement, no history of any other involuntary movements, no history of autonomic involvement in the form of sweating, pallor or erythema, no history of Cox or Cox contact, no history of any blood transfusion in the past or in the family, or any bleeding disorders, no history of fall or head injury, no history of loose motions, vomiting or decreased urine output. There is no history of sudden death or stroke in the family. Birth history. Mother was not ANC registered and she has not taken any supplements or any immunization. It was a full-term vaginal delivery conducted at home by Dai. Baby cried immediately after birth, and birth weight according to the mother was average. The cord was cut by new sterile blade. Breastfeeding was initiated half an hour after the birth. There was no history of any postnatal complications. Developmental history. Gross motor neck holding was achieved at 3 to 4 months, sitting with support at 5 to 6 months, sitting without support at 7 to 8 months, standing without support at around 1 year, walking without support at 1.5 years, and running at 2 years. Now the child can go upstairs and downstairs at 2.5 years, but the child still cannot jump. Fine motor, pincer grasp was achieved at around 1 year. Now the child can scribble on the pen since 1.5 years. Can eat with spoon with spillage since 2 years, but the child cannot dress or undress. Language, monosyllables since 6 to 7 months of age, bisyllables 1 year, and now the child can speak simple sentence with 2 to 3 words. Social smile at 2 months, recognizes mothers 3 to 4 months, and stranger anxiety is present in 7 to 8 months. The child is having now bowel bladder control, which is achieved since 2.5 years of age. Immunization history, the child is immunized till date as per the universal immunization program. Dietary history, the expected, the child is having a deficit of 235 kilocalorie with adequate protein intake. And the family and the socio-economic history, the mother is 26 years old, studied 8th standard, and she is a housewife with father working as a laborer, earning 5 to 6,000 per month, and they belong to lower socio-economic strata according to the modified Kuppuswamy classification.
Let's start with the discussion. So, how would you analyze the history? The first part. Start with the first part. You said it started with a rash.
Started with a rash, with a prodrome of coryza, you know. So it could be some viral exanthem which initially began.
So do viral exanthems begin with the exanthem?
They begin with fever and then followed by rash.
So how do you explain that?
It could have been a mild fever which parents would not have been noticed the fever.
Okay, so that's one possibility. What else? How did did they describe the rash on history to you?
They described like it was erythematous, like reddish rash which was present over the face, and then gradually over the next day it involved the trunk. Upper limb, trunk and the limbs.
So in other words, what I'm asking is that the first thing that strikes you is that there was nothing before the rash, and sudden direct appearance of a rash. What other thought should cross your mind? I mean, viral exanthem without fever is one atypical situation. But suppose somebody comes suddenly with a rash, what other thoughts will cross your mind? Yeah, one sec.
Can be vasculitis, connective tissue disorder can be.
Suddenly on day one. See, what I am asking is, do not take into cognizance the subsequent history. Subsequent history is yet to come. We are developing an approach. So I am saying a 3-year-old comes to you with a maculopapular rash of 1 day. There is no fever, nothing. So how do you approach this? What other thoughts will cross your mind?
So any food allergy or any drug allergy.
Okay, very good. So food allergy, drug allergy. So what question will you ask? Which will tell you whether it can be this or cannot be this.
History of consumption of any seafood in the...
Okay, which is just, maybe, may not be. First of all, one question which will tell you that yes, this could be allergy to some food or drug or whatever.
History of atopy in family. Or is the child prone to get the same episodes?
Okay. Any more questions? Speak into the mic. Please ask for the mic.
History of previous episode?
Yeah, that's what she said. Right. What else?
History of itching.
Excellent. So history of itching will tell you that this is allergic, and then of course all these other questions are very relevant. What else? What else will what else will you ask to decide whether this rash has a sort of an allergic basis? You said description of the rash. So what I'm trying to say is that in a rash, Prasad.
Is the rash subsiding on its own?
Excellent, excellent. So is the rash subsiding on its own and quickly coming back at other places? This tells you what? No, what is this kind of a rash? You're right, it's allergy. A rash which comes at 9 a.m., disappears at 2 p.m., only to come at another place at 3 p.m. What is this kind of a rash?
Even
Urticaria, excellent. So, because this child has funnily started with just a rash, so you need to ask all this. Now, okay, go on beyond that?
And then the rash was present for a period of 2 to 3 days, which subsided. And
so those 2 to 3 days, there was just a rash and nothing else.
There was associated coryza and mild fever.
Okay. Fever was not documented.
Not documented.
Okay.
And 4 days later, child developed fever, cough and breathlessness after the onset of rash.
Okay. So now everyone heard that story of fever, cough and breathlessness. Now tell me, what do you make out of this story of fever, cough and breathlessness? So my first question to you is it a viral infection or a bacterial infection, or you can't make out? Or you want to ask more questions? Or it's not an infection at all? That's also possible. So tell me, what do you think?
It could be a viral infection, sir.
Why? So take each component. You said fever, cough, breathlessness. So take the fever. Tell me what you interpret from the fever. Take the others.
Fever of high grade, and which was intermittent and responding to oral medications. So
high grade fever at the onset itself, it was high grade?
Yes, sir. The father describes the fever to be high.
Fine. So high grade fever could be viral or bacterial, both. Okay. Then interfebrile, you said the child was not well, which suggests bacterial. Response to antipyretic was good, which suggests viral. Now what about the sequence? I didn't get the sequence on the history, and that's why I'm asking this question. What about the sequence of the fever, cough, breathlessness?
Fever, the child developed fever. The child developed fever and then followed by cough.
When?
A cough on the second day of the fever, followed then by breathlessness.
When?
Over a period of 3 days. First the child developed fever and then cough and then breathlessness. For which then they admitted the child to a local hospital. For which
so by third day the child was breathless.
Breathless.
So now what does this suggest? Does this suggest a bacterial infection, viral infection? What?
Bacterial infection, initially the breathlessness would have been at the it would be more earlier.
Or anybody wants to react to that? Okay, I would have said that in a bacterial infection, the cough would be later rather than saying breathlessness is earlier. So if this sequence is correct, and if the child was significantly coughing within first 1 or 2 days of the fever, it is less likely to be bacterial. Okay. Now I said it need not be infection at all. How do you react to that? So what do I mean when I say that it need not be infection at all?
It could again be an allergic disease going on to any hyperreactive airway disease.
So a child who has a hyperreactive airway can also cough and become breathless, and fever may be a trigger. So for that you need past history of such episodes. Is there
no
any?
No past history of such episodes.
Okay, fine. So now where are we? So we had a sort of a viral with maculopapular rash and mild fever and all. Then 4 days later, high fever, cough and breathlessness. So now is this a complication of the first viral, or is it a second viral, or is it a second disease, or what?
It can be a complication because according to them, from the onset of rash, the child was not active as that before the illness. So it could suggest some progression of the initial illness.
Okay. Okay. Sir, you want to say anything? Okay. Fine. Then?
And then there was history of left-sided focal convulsions 7 days back.
Yeah. So now describe the convulsion. Okay. 3-year-old, na?
3.5 years old.
So 3.5-year-old child started with a maculopapular rash over the whole body with very mild fever and some running nose. Lasted for 3.5 days. 4 days later developed high fever, followed by cough, followed by breathlessness in a span of 3 or 4 days, and was then admitted to a hospital and treated for that, and followed 3 days later by a left-sided focal convulsion.
The focal convulsion was in the form of clonic movements of only the fingers of the left hand, not associated with secondary generalization or deviation of angle of the mouth or frothing at mouth.
Okay. So, what do you make out of this, of the focal convulsion? At first, actually, I want you to repeat your description of this convulsion because I have some issues there.
The child had left focal convulsion in the form of clonic movements of the fingers.
Speak in the mic properly.
The child had left focal convulsion in the form of clonic movements of the left fingers, of the fingers of the left hand, lasting for 2 to 3 minutes, not associated with secondary generalization, not associated with uprolling of eyeballs or frothing at mouth or any deviation of angle of mouth.
Okay, further.
Associated with query postictal drowsiness, but the parents actually do not exactly know how was because the child was sleepy. So query it was postictal drowsiness, and the child had multiple such episodes of convulsions over a period of 1 to 2 hours, in the gap of 1 to 2 hours over the day.
Yeah. So my question is, can a focal convulsion give you postictal drowsiness? That's what I wanted to ask. No. So then what does it mean? They are saying that the child was drowsy. So what are your thoughts on that?
Sir, how was the sensorium of the child before the onset of convulsion? Was this an encephalopathy and child developed convulsion?
The sensorium was normal. The child was able to communicate with the parents well. There was no altered sensorium.
Even during a convulsion, there was no altered sensorium. I mean, in the seizure, when the child had twitching, at that time the child was normal sensorium wise or he was not normal?
The child was not speaking during the episode. He was
eyes dazed, open,
eyes
looking at one place.
Eyes open, only movements of the fingers with no communication during the event.
So how would you interpret that as?
It could be a subtle convulsion with some element, some cortical involvement causing.
Would you say that this behavior is normal or not normal?
Not normal.
Not normal.
Yeah, so I think Arpita will lighten us.
You would like to tell us whether it was a simple partial seizure or a complex partial seizure. You said that the sensorium was not normal and the child was having subtle movements of the left side, and this he had repeated movements every 1 to 2 hourly, and in between that sensorium was altered. So now would you like to tell that what was it? Was it a complex partial status epilepticus you feel, or it were multiple episodes of simple partial seizures? As sir asked you that the sensorium was not normal and the child had multiple episodes, recurrent episodes also, with do not know about the sensorium in between, whether he was sedated because of the anticonvulsant medications or he had postictal drowsiness.
the child had received some IV medication after the convulsion, so the sedation could be probably because of IV sedation.
That was after the end of those 2 hours or whatever, no? But in those 2 hours also he was drowsy.
He was post-ictally, the child was drowsy.
Correct. Post-ictally means, see, we are saying that we had multiple episodes. So post the first episode of twitching of fingers only the child was drowsy, right? So and the medication was received 2 hours later.
So it goes in favor of a complex partial status epilepticus. Because definition wise, if you see, when there are 2 or more convulsions and when the sensorium is altered in between the convulsions, then we take it as a status epilepticus.
So, yeah, my question was just that, complex partial is associated with behavior change or sensorium alteration. Means, what I'm trying to say is, if the child is drowsy, does it mean that it was a generalized seizure which was not picked up? I mean, there were no motor movements, but it was essentially a generalized seizure.
So you're absolutely right. As she said that the convulsion began from the left fingers, so it was to begin with a simple partial followed by complex partial going into status epilepticus followed by generalization.
So means, I just wanted to make a point that focal cannot have a alteration of sensorium. So,
because he started having fever, rash and breathlessness and focal convulsion. So only one entity herpes simplex can cause focal.
See, we are coming to the final diagnosis much later. First we are trying to analyze each part of the history, then we'll make a whole picture. Okay? So we'll come to that, your possibilities later. Okay, now you also said incontinence of urine and all that, no? Further some...
Not associated with passage of urine or stool during the event.
So again, my point was just that there are some events associated with a seizure which can only occur if it's a generalized seizure. Cannot occur if it's a focal seizure. Okay? Okay.
There was history of multiple such episodes of convulsions of similar semiology for which the child had received some IV medications, and there was about 6 to 7 episodes during the day, after which there was after receiving the medication the child didn't have any further episodes of convulsions. Then following these convulsions the child was then transferred to a tertiary hospital where 3 to 4 hours later, after the last episode of convulsion, father noticed that there was no weakness of the left side of the body in the form that the child was not able to move his left upper limb and lower limb at all.
Yeah. So now how do you interpret this? How do you interpret the seizures followed by inability to move the left half of the body? Anybody?
Initially focal lesion, it became gradually progressive. So that child had convulsion, then weakness of the extremities. That indicates progressive lesions. In the brain.
Progressive lesion.
So could this be Todd's paralysis, post-ictal Todd's paralysis, which is now coming back? She's regaining her power again.
So respond to that.
The weakness had lasted for 5 days.
5 days. It was static.
So Todd's paralysis, by definition, it should be
less than 1 day.
24 hours.
It should be less than 24 hours, and you have an etiology called as reversible ischemic neurological deficit, which can be around 48 to 72 hours. So this is beyond it. And she is told that the power is almost 0 by 5 for 5 days. So it is unlikely to be a Todd's paralysis.
Okay. So,
Rajesh,
yeah.
But if Amol, you were there on day 1 and you had just treated the seizure, considering Todd's paralysis is not incorrect. With the evolution of the disease, you would think that it's not fitting in. But yes, at that point of time, that's a good thought.
No, so now how do you interpret this seizure and the subsequent paralysis in terms of, let's say, anatomy, pathology, etiology? So any thoughts on that? What are your thoughts?
The development of seizures could suggest a cortical involvement, and then followed by weakness of the body, involving it could be either the cortical and the or spreading of the cortical lesion into the subcortical region. So the weakness could either suggest a cortical, subcortical lesion.
Arpita, would you like to?
I think a stroke can present either ways. It can come as seizures, refractory seizures, and after the seizures are gone, it is noticed whether there is paucity of movement or no, or otherwise it can come as only paucity of movement. So generally in infancy or in children around 2 to 3 years of age, it can come with multiple seizures when the paucity of movement is not noticed and later on there is paucity of movements. So this is one of the presentations of acute infantile hemiplegia where they can come as seizures. And this child had come with an earlier prodrome of fever, rash and breathlessness. So it was a prodrome of fever, rash, breathlessness with left focal status epilepticus, and on recovery after the status epilepticus there was noticed that paucity of movements on the same side as the status epilepticus. That is what
Dr. Arpita, half the number of hemiplegia begin with a focal seizure and remaining half will present as a. So because there was a seizure and there was it was not cause and effect relationship. It started and need not be entertained as progressive lesion. There were acute symptomatic seizures in this particular child, and 3 events have occurred one after the other rather too soon to be able to separate them. So the whole thing has started with a rash, with some fever, and 1 or 2 days when the child was alright, and again there was cough cold, which was again a part and parcel of the same thing, which ultimately resulted in a seizure and a hemiplegia. So all this must have been an infective encephalopathy resulting ultimately in a hemiplegia.
Dr. Arpita, can you please clarify on complex partial, because loss of consciousness or altered sensorium is a feature of complex partial. Just wanted your opinion on that.
Basically, complex partial seizure is when you have loss of consciousness. Now that terminology is no more there, and they say just altered awareness in the child, as sir very correctly said that there is some behavioral problem. So complex partial seizure, child will have a behavioral problem. He will go in a behavioral arrest, and there is something called as automatisms. So there are movements which are, abnormal movements like lip smacking, grinding of teeth, with behavioral arrest goes in favor of a complex partial seizure.
From the description of seizure, from the description of paralysis from the parents, do you think it's a dense paralysis? Will that help you diagnose where the anatomy is?
It is a dense paralysis.
And then the cortical involvement is not so great. So it's your dense paralysis of
internal
capsule with some spread which is going towards the subcortical region, which explains if it had been a cortical event, he would have gross altered sensorium. He would be unconscious. So you think, the story is so beautifully evolving that tells you probably it's an internal capsule issue.
So can you tell what happens, means when the lesion is in the cortex in this child, what goes in favor of a cortical lesion and what goes in favor of a subcortical lesion? Means you are trying to say what lesion it is now.
In the cortical lesion, cortical lesion, because of the ischemia, it has been manifested as seizure with behavioral changes or in the form of altered sensorium, and then presenting with dense hemiplegia with then involvement of the internal capsule.
So a cortical lesion will by and large come with altered sensorium, seizures, and the hemiplegia would not be that dense. And a subcortical lesion would not have convulsions but will have a dense hemiplegia, and the internal capsule will have a dense hemiplegia, and there would be a hemisensory deficit. So in this child we have still not examined the child, but going that there are convulsions, there was some amount of altered sensorium, and with a dense hemiplegia it could be a cortical plus subcortical or internal capsule involvement. That would be the localization on the history. So you want to go ahead now? What do you think is the etiology?
There was a sudden.
So means the question is it just that the viral infection has spread and it's a viral encephalitis, or is it ischemic event or is it what else? What do you think?
It could be an ischemic event because of sudden onset of dense hemiplegia involving the left side of the body. So it could be an ischemic event involving either of the territories of supplying the brain.
So why is it not viral encephalitis?
What goes in favor of an ischemic event and not an encephalitis? Means what symptoms that the child has more in this case?
In case of ischemic encephalitis, the child has a dense hemiplegia with normal sensorium post the event. While in viral encephalitis, the child might have been persistent with altered sensorium, not regained the consciousness as early as this child has been regained.
So it is more likely to be an ischemic event since there is more of a motor deficit and the sensorium of the child has become normal. Whereas in a viral encephalitis, there would be more of altered sensorium, although there can be a focal neurological deficit as well.
Arpita, another thing, in a viral encephalitis or encephalopathy, the sequence of events would be different. He would come with altered sensorium right at the beginning because the involvement of the CNS is right at the beginning. And in this situation, the seizures and the alteration in sensorium have come later. So, encephalitis is unlikely in this.
And by and large, when we talk of encephalitis, we are talking of herpes simplex. So, herpes simplex does not come with a stroke, such a large kind of stroke, until and unless it is an herpes zoster. If it is a second reactivation, then it would come with such a kind of history of paucity of movements. So, herpes simplex will predominantly come with convulsions only. Might come with a stroke, but as you rightly said, the history goes in favor of more like an arterial ischemic stroke.
Any other points against encephalitis? Many have been discussed, but anything else?
Fever, how can we explain in fever in this condition then, sir?
In which condition?
This condition, suppose it's stroke, then fever, how can I explain, sir? Then it is infective etiology.
No, the original event is a viral infection. No? That's how the process has started. But can a viral infection, the viral infection can mediate this through different mechanisms. One is encephalitis, where the whole brain is inflamed or infected. And one is it can cause secondary effects on the vasculature and cause the thing. So fever is part of the original viral infection. My question is, any other one or two small points why it's not encephalitis? Do you have other signs of raised ICP? Do you have vomiting? So you want all that, no? So all that is also not there. Yeah, so that's why less likely raised encephalitis. Fine, just quickly explain your no histories.
No, but what is the pathology finally?
Yeah.
What have we decided?
What is pathology? Pathology, what is the...
Is it, I mean, Dr. Arpita said this is a...
Internal capsular region with extension into the...
Hold close. I think first thing I want to know how well this child was before all this started. I haven't heard that. Was he a malnourished child? Was he a well-nourished child? How well was he? I think that's the first important thing that I have to know. Because we haven't talked about etiology. We have just said it's a stroke. Stroke is all right, but what's the cause of a stroke? And I will not know unless I know how did the child start. So, was the child well-nourished or was the child malnourished? If he was malnourished, what was happening, why he got malnourished? Was he a sick child? What kind of sickness he had? At this age, he has no reason to be malnourished nutritionally. He should have been a sick child. Then what kind of sickness he had? So is this the sickness only of these so many days, or it has been there slowly coming up all along? Are you aware of any of these?
According to the parents, there is no history.
Speak in the mic properly.
According to the parents, there is no history suggesting of any malnutrition.
No, the parents won't know malnutrition. I want to know whether he was fine.
According to the...
Every time they will say he was all right. How did you ask that? Was he playful? Was he active? Was he sleeping well? Was he feeding well? Was he behaving well? So many questions will tell you whether this child was all right or not. If you ask the parent, was he all right? Yes, he was all right. That all right doesn't mean anything. And to me, that's the most important part to pick up in etiology.
If we say that he was well nourished, okay, then I think problems are different. That's number one. Second is, whatever I heard, the first story of 2-3 days of fever and rash. Thereafter he was all right. All right for some few days.
All right, then fever.
Yeah, but all right for some few days. 2-3 days. Then he comes with breathlessness.
Fever, cough and breathlessness.
Yeah. So what kind of illness are we talking about? Fever and rash, we say it must be a viral infection. All right. Not necessarily so. It could be a bacterial infection as well. Just because you have a rash, you can't just say it's a viral. It got better in 2-3 days. He was all right for 2-3 days. Why should an infection that got all right starts another illness with fever, cough, breathlessness? Are we talking about the same illness going further worse? If so, why he was all right for 2-3 days? Why should a viral infection subside to be all right for 2-3 days and then complicate? I don't accept that. So then I want to know, what treatment was he given? Was it a bacterial infection and he was haphazardly treated? And he got apparently well, but he was not well. He starts getting breathless. Which neurological disease comes with breathlessness first? Okay. So that's my worry. What was his breathlessness like? How long did it last? Did he have a respiratory complication or a cardiac complication? Now, if he had one of those, what made him get into a CNS problem? I think we are not very clear about all this at all. If I have to kind of get the whole thing together, can I say that this was a streptococcal infection with a rash? Somebody gave some antibiotic. He got a little better. He was never all right. Again, I want to know how well he was in between when you say he was all right. He could have been all right as far as fever was concerned, which means the fever, high fever, became no fever or low fever. But was he active? Was he feeding well? Did he appear well? Saying that he was all right in between does not make us clear whether he was really all right. Now imagine you had a bacterial infection, somebody gave an antibiotic, he was apparently all right, but he was never all right, he came back. I can understand then he is still developing a further bacterial infection. Now he gets a pneumonia, for example. Then what happens? Who treated him? What did he get treated with? If I carry on that story, then did he throw up a local lesion, that means a small brain abscess there of an haphazardly treated child? Then what was the kind of fever he had? So I think on this history we have many issues. Now give me a malnourished child. Was he already harboring some disease like tubercle? He gets a viral infection. Okay. He flares up. Okay. And he gets a classical. In terms of neurology, you have an encephalopathy with an internal capsular lesion. Okay. Which pathology, which etiology has encephalopathy? There is no doubt there is an encephalopathy. You call it encephalitis or encephalopathy. Now, which encephalopathy or encephalitis has a hemiparesis and a severe convulsions as well? Then the common is, you have a vasculitis with encephalopathy. Why not call it a tuberculous disease? Which is classically an encephalopathy with a vasculitis. Okay. Bacterial diseases rarely do that. If this was a brain abscess, why should he have had that kind of encephalopathy? He would have had a localized lesion, headache, vomiting, maybe some localized thing. He would not be encephalopathic. So bacterial infection is unlikely. If it was a viral infection, the sequence of events don't settle in a viral infection. So if it is infection, it's tubercle. And if it's tubercle, then let him be not so well to begin with only. He can't be so healthy and suddenly threw up a rash and then a breathlessness and all that. So all this looks a little different. Was the breathlessness so-called was just an acidotic breathing of a central origin, and we are talking about a respiratory disease. So I think we would need to know a lot about that. I'm sure with this history I'm not very clear what we are dealing with, except to say that there's an encephalopathy with a dense lesion, and two together goes classically in a tuberculous disease. Okay. Could it be any metabolic complication arising out of this? Could it? So very unlikely. Why should there be an encephalopathy and a vascular? So I thought that these are the ways I would look at it, but I'm sure this story does not fit in very clearly as of now. And let's see what examination you have. You agree with what I said?
Perfectly right. It fits into tuberculous meningitis, which can have a large, the child is going on for a long given antibiotics, behaved little better, came with pneumonia and then could have got a stroke. It can fit definitely in a TB vasculitis child.
But what was the breath? What pneumonia was it? Was it tuberculous pneumonia?
No, I'm not sure
not
whether it was
clear.
pneumonia also. I was just told he was fever, cough, breathlessness, and then he developed that. I don't see this combination at all.
And breathlessness just for one day, which is not there anymore after the child has developed convulsions and vasculitis.
So I don't think he had a respiratory disease. He could be tachypneic. Well, tachypnea could be an early symptom.
Sir, we don't know whether the breathlessness subsided. The entire attention then went on the neurological.
No, but the point is, which breathless child is getting CNS? I don't see that. But can tachypnea be a central nervous system beginning of a disease? Yes. Okay. To begin with, it could be just a change in the respiratory rate, and then he becomes encephalopathy and all. So, I would discard breathlessness for my convenience of thinking or not able to think, whatever. And I think breathlessness and seizure, etc., doesn't fit in this child. Let's see where we are.
Sir, if we were to, there was a gap of about 3 to 4 days between the episode of breathlessness settling down and the onset of these seizures. And Tushar and I were just discussing, he felt that this could be an immune-mediated complication of the first illness with a gap of 3 to 4 days in between, which may be even tuberculosis, but that breathlessness and cough goes in favor of an airway disease which was not being treated properly, which got treated and he got okay with that.
I think unless, Anand, we know the details of what cough, severe cough, breathlessness, what breathlessness.
Before you came, actually we made those points that the sequence was funny of both the rash followed by the fever, and even within that illness of fever, cough, breathlessness, we made those points that those sequence was very odd, and whether it was 2 virals or 1 viral then break. But I think we'll have to just put it down as inadequate history and go ahead. And the only thing that seems to be clear is that whatever those initial illness was, then there was a break for 3-4 days. That was a clear break, at which time the child was CNS wise pretty normal, and then suddenly there was a partial seizure. This is the major outline which is clear, but the intricacies are missing, sir, of the first.
What I want to make it is that when the parent says normal, don't take it as normal. Get to the details that is really normal. For them, the high fever has gone down, so he is better. But was he behaving well? Okay. And I think many times this episode of a sudden CNS may have some subtle symptoms that were missed. And therefore, we are trying to say, once a fever rash, then a respiratory disease, then a CNS disease. I think all that could be just one CNS disease. So, we don't know that. Let's see where we are now.
I just thought we wanted to revise your no histories. So quickly go through no histories and explain why.
To rule out the other cranial nerve involvement, there is no history of...
Speak in the mic
to rule out any other cranial nerve involvement, there is no history of decreased hearing or difficulty in swallowing or change in their voice. There is no history of any involuntary movements, no history of autonomic involvement in the form of excessive sweating or erythema. There is no history of COX or COX contact, no history of any blood transfusion in the past or family or any bleeding disorder, no history of loose motions, vomiting or decreased urine output. There is no history of fall or head injury, and no history of sudden death or stroke in the family.
We'll examine the child. Is this child immunized?
Yes, sir. Immunized as per date.
Can you decrease the AC of this side? Any volunteers to examine the child? Come. Come on, 1 or 2 persons should come. Come. Any representative from the girls' side? So first, as usual, just inspection, and tell us on inspection what are your findings.
काय नाही बेटा, काय नाही.
Child is on lying down position. It's not sick looking.
Take 1 minute. Can you get a view of the child? Should I bring him आगे?
Instead of saying not sick looking, say not acutely sick looking.
Yeah, not acutely sick looking.
Repeat.
Child is lying down, not sick looking. Child is tachypneic. It's not comfortable in the bed because of anxiety. And at to examination, there is no.
Is he aware of what is going around? Is he aware of what is going around? How is his gaze? If you talk to him or if the parents talk to him, does he respond? Now, when the father was away, he was calling out for a father. So what does all that tell you?
He is interested in surrounding because he is just seeing the people and he is responding to father.
So I can say child is sick looking, sir, yeah, because acutely, because and pallor is there, generalized pallor. There is this positive movements of the left, both upper and lower extremity. Child is not moving both upper and lower extremity of left sided, but there is movement of the both right, upper and lower extremity. Child is not tachypneic.
नाम क्या है इसका?
Go on.
On head to toe examination, the head looks normal. There is no any facial dysmorphism. Obvious. There is no any cutaneous marker on the skin.
So Dr. Arpita is pointing out that with so many clothes on, you cannot make that comment just now that there are no cutaneous markers.
How would you like to tell neurological examination in this child? Means as sir is telling, child is sleeping. So just describe whether the child is aware of the surroundings, what it is. So just describe in one line what do you feel about the sensorium of the child.
Child is conscious. His behavior is normal, interested in surrounding, but child is uncomfortable.
Very right. You rightly said that she is aware of the surroundings, but she is very irritable. She is not comfortable lying down. And what distinctly do you observe that there is definite paucity of movements on the left side, and she is intermittently turning towards the father. So she is aware of the surroundings, but she is not responsive. She is not interested in the surroundings, and she is not alert. So the status of the child, rather than describing, like it is always better to describe in sentences rather than describing that she is drowsy or she is obtended or she is stuporous or something like that. That is...
Absolutely.
But you should know as well what are the definitions of drowsy, obtended, stuporous and coma. So you would just like to say, for the sake of what is the definition, how would you describe drowsiness, obtendation, stuporous and coma? Anybody from the audience?
I think just before that, if you just talk about AVPU, that's enough
Yes.
neurological. And I think that takes away all the difficulties of explaining correctly all these terms. So just tell us, where do you stand on AVPU?
Whether the
Of course you
sir
know
is
AVPU. Yes.
Her name is Sidra.
Come on, what is the difficulty? AVPU stands for what? A stands for?
Sidra. Hello.
Sidra. She is responding to verbal stimulus, so she fits in V.
Yeah. So
And V corresponds to what GCS?
V is verbalization, sir. V is verbalization, and
So roughly corresponds to 12 or above. Roughly, you have to have rough markers, no? Okay. Anything else that you can make out on? See, we are just making it a habit. Last time Rajesh sir also said the same thing. Get as much information on observation before you touch the child. So what other observations you want to make on the face, which will quickly tell you some neurological findings? They may be negative. So know this, know that, which tells you that.
okay. There is no ptosis or any abnormal eye movements. There is no facial asymmetry. There is no deviation of angle of mouth. There is no obvious ear discharge on both the ears.
You would like to see the facial asymmetry when the child talks or something, or just at rest?
on crying it is very helpful. So we
So
like to
when
make
crying,
the cry.
what did you observe?
On crying, there is deviation of the angle of mouth on the right side is there.
Correct. And even at rest, if you see very closely, then there is flattening of the left nasolabial fold. And when she calls out, Sidra, Papa kidhar hai? Papa kidhar hai? When she calls out or when she cries, there is definite deviation of the mouth to the right side. Okay, what else on examination?
The positive of left side of the...
No, so to complete the cranial nerve observations, no drooling of saliva. So these all tell you that certain cranial nerves apparently are normal. So you can quickly run through that. Okay.
There is no drooling of saliva. She is making a sound, that is the speech is normal. That is
Okay. Now actually examine quickly and tell us what else you want to examine.
देखो इधर देखो बेटा.
So what do we observe? The child is able to see the object. It's a bright object. Sidra, idhar dekho. Yellow. Sidra, yellow. If you see, her extraocular movements are normal. She is moving her eyes in all the direction. So that goes in favor of your third, fourth and sixth being by and large normal. Sidra, आँख बंद करो Sidra. Now you see. Sidra, आँख बंद करो. Now you see a definite deviation of the angle of the mouth to the right side. If you see that the left palpebral fissure is also slightly widened. So that goes, whereas when she cries, you look for the frowning. There is bilateral frowning present. So the upper face is normal. Okay, so this goes in favor of a left UMN facial palsy with normal third, fourth, sixth. We could not test the olfactory nerve. But if you see, intermittently she turns towards the right side, the eyes towards the right side, so she has a right gaze preference. So how do you interpret that gaze preference? What do you feel about the gaze preference?
There is a right-sided gaze preference is there, so it means she is having the palsy of right-sided median rectus muscle.
I said the ocular movements are normal when the child is moving her head. The eyes are moving in all the directions, but she prefers to look towards the right side. So that is called as a right gaze preference. So where is the lesion when you say that there is a right gaze preference?
Occipital. There is horizontal gaze palsy which is getting occipital.
See, we are not talking of palsy. Palsy has been ruled out. Just now, Dr. Arpita examined. Now, what does a gaze preference mean, she is asking.
Anybody from the audience can tell what do you mean by a gaze preference? When there is no palsy, but the child prefers to look towards one side. Anita? So basically it is a cortical irritative lesion, means will deviate the eyes to the opposite side, and a cortical destructive lesion will deviate the eyes to the same side. Okay, so this child is looking towards the right side, so probably there is a destructive lesion on the right side, that is our stroke which she has, or it could be an irritation on the left side, an epileptic foci on the left side which is diverging the child's eye to the right side. So in this case there is a cortical destructive lesion on the right side, so the child prefers to look to the right. Okay. You want to do the further CNS examination other than the cranial nerves? A cortical irritative lesion makes the child looks towards the opposite side, and a cortical destructive lesion gives a gaze preference to the same side. So in this case there is a right-sided stroke, so the child is preferring to look towards the right side. Yeah, left-sided stroke, but the etiology lesion is on the right side. The pathology, sorry, I mean to say right-sided lesion, so the child is looking towards the right side. And vice versa, if there was an epilepsy on the opposite side, then the child would look on the right side. Other CNS examination that you would do?
Further motor system examinations. Nutrition generalized, there is nutrition average of the child, but actually measurement of the both upper and lower extremities.
Please speak louder and please hold the mic close to you.
Nutrition are generalized, normal average nutrition is there, but I have to do the measurement. For that I can compare the both sides of nutritions. Then the tone, actually on inspection child can see there is movement of the right side is there, so tone is normal on inspection, and the left side is also there is no positive movement, but the palpation and the flappability test I have to do for.
So you do the complete examination of tone. How will you assess the tone in any child? Anything before this you would like to do? Any crude method to know what is the tone of the child? Yeah, you would like to see the similar thing in the lower limbs? So when you are checking for tone, you need to check the tone by a crude method first. So if I am doing a log roll, means holding the child by the knee, I am looking at the tone at the ankle. So definitely there is hypotonia. Then to look the tone at the knee, I just lift the child's limb, flick the child's knee from the popliteal fossa, and if the child is hypotonic, whereas this leg is normal, if I do it on this side, the child will not be able to lift the limb above. If it is hypotonic, whereas in the normal child, the limb can be lifted off the bed, and in a spastic child, it can be lifted more faster. So this will be one crude method. Similarly, he showed in the upper hands that we see were for hypotonia. And the other things, you look for the palpation of the muscles. What are the feel of the muscles, whether they are flabby or what, that is the second thing. And the third thing is to look for passive tone followed by active tone. So in this child, on the left side, the tone is almost 1/5. So we would like to go and see whether it is 2/5 or no. In a child who comes walking to you, we definitely know that the tone is more than 3/5. So you assess further to see whether it is 4 or 5. But in this child, we will not begin with 3, 4 or 5. But as the tone is 1/5, we would like to see whether it is...
We're talking of power or tone?
Power. I'm sorry. I'm confused. Yeah. So power, we would like to see whether it is 2/5 or no. Okay. So first I finish the tone in lower limbs by passive stretching. You do first by the slow movements and then you do by the rapid movements. You would like to do it?
Dr. Arpita,
yeah.
Can you please tell us about active tone and passive tone, how to examine? Some examiners are fond of asking.
Passive tone, you just need to do slow movements first of the limb followed by rapid movements. And you need to see whether there is any rigidity or any catch that you see during the rapid movements. I'm getting some resistance in the left lower limb. Then I need to check the tone of the adductor group of muscles. Need to check for the hamstrings, whether there is any spasticity or any hypotonia. In the upper limb, same. I need to see slow movements followed by rapid movements. The right limb is absolutely normal. Turn the hand from prone to supine position to look for any pronator catch. In the left limb, doing the similar movements, fast, slow followed by fast. Again, I am getting some catch and some resistance, and there is a pronator catch. So this indicates that there is spasticity in the left upper limb more than the lower limb. Right side tone is completely normal. Active tone will be when the child is cooperative and the child can apply resistance to your movements. So that will be active tone. So in this child, since the tone is less than 2/5, I would be able to check by these methods.
Madam, that can explain this flappability also can explain the passive tone checking also.
Yes. You would like to say the power? So what is he doing? He is trying to stimulate whether the child is able to move the left side or no, to see for the power. What else can you do? What other tests can you do for seeing whether the left limb is moving or no? You have a cloth. You can just put a cloth on the child's face and see what if the child uses the hand to remove the cloth. आपके पास रुमाल है? So now just observe if the child is, see the child is not using the left limb at all. He is trying to remove the handkerchief by the right hand. And the child is not moving the left, both upper and lower extremities. So we say that the power is less than 2 by 5. 1 by 5 to say for a flicker of contraction is very difficult. So definitely the power is less than 2 by 5. You'd like to say, check the reflexes. So what is the observation? The knee reflexes. How much? You would like to tell the grade of reflexes?
It's around grade 4. Knee jerk is there, but it is grade 4. But now I have to find out other reflexes also that I can.
What is grade 4? With clonus. So has he checked for clonus? So you check for clonus and then you can comment that whether it is grade 4 or no. So now if you did then there was hyperreflexia. There was also a crossed adductor response, which suggests that there is hyperreflexia. Grade 0 will be reflexes absent. Grade 1 reflexes present with a Jedransky's maneuver. Grade 2 will be the normal ankle jerk. Ankle jerk is never brisk. Grade 3 will be the normal knee jerk. So knee jerk is always brisker than the ankle jerk. And grade 4 will be brisk reflexes with clonus. And clonus, again we go whether it is a well-sustained clonus or a ill-sustained clonus. So can you show the method how to do the clonus?
Ankle clonus or patella clonus. For ankle clonus, we have to flex the knee and the ankle. And suddenly you have to get the flex the ankle and then you have to keep it sustained.
You never ever hold the gastrocnemius. Because what is ankle clonus? It is a stretch reflex. So you are holding the muscle. You can do ankle clonus in various axes. If you are not getting in one axis, then you can change the axis and see whether there is clonus or no. So if you see, I am getting on the right side, there is ill sustained, hardly 1 beat or so. Now let's check on the left side. You saw that? I am getting at least 5 to 6 beats. And which clonus is more important? Which clonus is more important, a unilateral clonus or a bilateral clonus? A unilateral well-sustained clonus is more important rather than a bilateral ill-sustained clonus. And clonus should always be taken with other signs. Per se, clonus should never be used to localize. So unilateral well-sustained clonus with hyperreflexia, with other reflexes, superficial reflexes absent, goes in favor of a corticospinal tract lesion. Upper limb reflexes?
What are the other conditions in which we will get an ankle clonus but not a corticospinal tract lesion?
Other conditions in which we will get in?
We said we should corroborate all the findings and say it is corticospinal tract.
Yeah.
So if you get only clonus,
I mean to say an ill-sustained clonus shouldn't have so much of value if it is not associated with hyperreflexia and absence of superficial reflexes. always be bold in doing the reflexes and do the jerk from your wrist and not holding the hammer tight. The freely you hit the hammer to the tendon, you will get a better reflex. So to look at the biceps reflexes, you just keep the child's hand both flexed. I don't know, some examiners prefer that you should keep a hand on the tendon, but I'm used to doing by just directly doing the tendon. You saw I got a reflex. You saw the biceps reflex? Okay, so he is having bilateral bicep reflex present. This will be your biceps. This will be your brachioradialis. So you semi-pronate the hand and you look for brachioradialis. And then you just pull the hand towards the abdomen and you look for your triceps reflex. Okay? Is everybody able to appreciate how to do the upper limb reflexes? Now the superficial reflexes.
Superficial reflex is corneal conjunctival reflex also you can do. But better to other reflexes you can start like abdomen reflexes. For abdomen reflexes along the midline we can go from lateral to the midline. All quadrants.
Correct.
Upper quadrant, lower quadrant. That is upper quadrant, this is lower quadrant. Suppose the reflex is present, then we can go for other superficial reflexes as plantar reflex. And
so can you show how to do the plantar reflex?
For plantar reflex we have to go straight from the right sided but up to the second toe but not crossing the first toe.
And if a plantar reflex has to be positive, it will come when you strike the lateral side only. So never ever go up to the ball of the first toe, otherwise you get a plantar grasp. You will never get a reflex. So just stroke the lateral end, lateral surface. So what are her plantars? Bilateral plantars, upgoing. So can you summarize your examination findings?
Do you have any signs of raised ICT in this one?
Yeah, for science I have to find knee jerk.
So just examine and tell me whether there is the raised ICT in this one.
Knee jerk you already saw. Sir is asking what are the other signs of raised ICP which you will look for. What are you looking for?
Neck rigidity.
Okay. It's not a sign of raised ICP, but anyway. What else?
From inspection, child is awake, conscious, but it's a fundoscopy is helpful for me. The fundoscopy examination helpful signs of raised ICT.
Any other sign?
And involvements of false localizing signs. So abduction now is not here. So false localizing abduction now false is not here. So that is also not there. Second knee jerk is bricks. So that also indicates the signs of raised ICT.
Anything else? There's one more thing that you should look for, and then there are some things in general examination which you can repeat.
Alter sensorium
Sign.
What is Macevan's sign? What is Macevan's sign? Anyone wants to come and demonstrate?
See, when you start looking for signs of raised ICP, the first thing you should start is with seeing the sensorium of the child. That will give you your first clue. And if the sensorium is altered, then you are going to be looking for it even more aggressively.
So Macevan sign usually gives unconscious patient that help to find out the signs of raised ICT, sir.
Macevan has nothing to do with consciousness or unconsciousness. Anybody who said Macevan's, please come and do it.
Yes, sir. Understood. Okay, I will do Macevan sign.
She's coming now. Since she has taken the effort, let her do.
Child is in midline. We have to focus on one side, and we have to try to listen to the sound.
No, you do it properly, then don't describe, do it. Is that the way?
Or otherwise we can auscultate with the stethoscope.
Okay. For seeing the Framatton sign, we have to percuss away from the suture lines. And we can hear the we can hear the crack point sign, but for that there should not be closure of the sutures, sir. It should be open suture.
There
Should be there.
There
If
should
it
be
is
a
open,
closure
then
of-
we can't listen to that sound.
Obviously, after the sutures have closed, you look for massive one. So, important thing is to lift the head from the neck and then don't hold the head because then it will dampen your tap. Okay? And other things you mentioned, so sensorium, fundus, then in vital signs you look for pulse rate, BP. Okay, so all these will be contributory. Fine.
Actually, you could have said that acute raised ICT is different than a chronic raised ICT. If an examiner asks you what are the signs of raised ICT, you could say that acute and chronic are different. That's number one. Acute is what he was saying. There could be herniation syndromes, and I think that is another important. So what herniation syndromes do you know, and how do you pick up clinically? Largely seen in an acute condition, but sometimes in a chronic condition, if you happen to intervene, do a lumbar puncture, etc., you may get into trouble. So, are you aware what's a transtentorial herniation?
You want to talk about herniation syndromes or anybody else wants to talk?
There are herniations, transtentorial one herniation, other herniation is uncal herniation also. Transtentorial herniation is impending, it is a severe condition actually. There is herniation of the brain stems, cells having impending respiratory failure, and
Yeah. See, basically herniation syndromes, there are actually 5 herniation syndromes that are described. But what is important, what sir was trying to tell us is that we must remember that when the pressure starts rising, the herniation of the brain occurs first through the tentorium and then through foramen magnum. Now, foramen magnum is lower down, that is the 4th and 5th grade of herniation, that is severe. Once that happens, it is irreversible, the damage is irreversible, it is life-threatening. But when the pressure starts rising, initially you have uncal and then midbrain, upper and lower midbrain herniation. There you will pick up initially with just a pupillary abnormality. That's how it will start, and then it will progress to involve respiratory abnormalities as it goes down to the 4th and 5th grade. And of course the posture initially will be decorticate, then it will be decerebrate. So this is how it will progress, but what you have to start looking at is the pupillary abnormalities. That's the early stage which can be reversed and which is the stage at which you should pick it up.
And I think the third nerve examination, largely. Okay. So it will be good that if you're suspecting any neurological disorder, even talk about such things, and I think that would make a lot of sense. Also talk about the respiration. Okay, in different lesions, you have a different type of a respiratory pattern. Well, we see generally in an acute condition, yes, so in an exam you have a chronic thing. But the pupils, respiration, these are all important parts of the clinical examination of a neurological disease. And therefore you would say, what kind of respiration is this? And I think that also tells you where the lesion could be. Lastly, autonomic nervous system. Don't forget that also. Sometimes, and especially in a TBM, you would get even some changes of autonomic nervous system, like a palmar erythema, tachycerebral. So these are also worth looking at. See, these add on in an examination to tell an examiner that you have done so much more than tone power everybody will do. But I'm sure that most of the candidates have failed in demonstrating tone. Don't take tone as a very simple measure. Okay, demonstrating rigidity, spasticity is not easy unless you practice. And lastly, in a given child, you can have multiple types of spasticity, rigidity, dystonia, all in one. So when you show an examiner a spasticity, he will show you a rigidity as well. And there could be multiple types of tone abnormality in a given patient. So you need to know how to separate them. Okay. Madam was talking about fast velocity, slow velocity. Somebody would talk about both the groups of muscles, agonist and antagonist involved, as against only one group involved. Then the rigidity you go on doing repeatedly, it loosens up, spasticity remains the same. So there would be so many such abnormalities, right?
So anything that we missed in examination? Any different findings? Speak in the mic, please.
In the anthropometry, the child comes under moderate acute malnutrition. So, okay.
Give us the anthropometry.
Weight is 10 kg, which falls between -2 to -3 standard deviation. Height of length of 89 centimeters, which falls in -1 to -2 standard deviation. Weight for height falls in between -2 to -3 standard deviations. And the mid upper arm circumference of 13 centimeters.
Okay. Anything else? So how will you summarize the findings and then we'll try and interpret them?
3.5 years old female child, completely immunized, developmentally normal, with acute onset of left-sided hemiplegia, with left UMN facial palsy, without any other cranial nerve involvement, without bowel bladder involvement. Without any apparent sensory nerve involvement, sensory system involvement. So most likely it could be infarct involving the internal capsule region spreading onto the cortical area. Could be involving the most likely involving middle cerebral artery territory. That's it.
And what about the etiology?
Could be some infectious etiology query. Could be tuberculosis infection.
Why tuberculosis?
In the setting of malnourishment with an acute onset of sudden onset of weakness, causing an infarct or something.
So that's not really a good enough reason. No, means setting of malnutrition is correct, but any malnourished child with acute onset or neurological lesion is not TBM, no? So any other reasons you have for calling it tubercle?
No.
Sir, I think we saw bilateral plantar extension. So this is a bilateral lesion. Well, you may have a hemiparesis on one side and a vascular lesion, but the lesion is bilateral extensive. So that's one. There is also an encephalopathy, that's true. So I think it looks like a disseminated lesion with a definitely a vascular lesion on one side, but even the other side is not normal if the plantar is extensive. So that tells me that it's much more a disseminated lesion in the brain. And to me, more the disseminated lesion with some localization. See, viral infection is a disseminated lesion, but rarely a localization. And a bacterial infection is mostly a localization, but rarely a generalization. But when you get both, I start looking at whether it's like a tuberculous disease, simply by that. Acute bacterial meningitis, okay, and viral encephalitis are too extreme, and this is meningoencephalitis. So there's something like that. What else could it be theoretically? Could it be any systemic inflammatory disorder we are talking about? There is some rash, there is some vascular complication. Unusual at this age, yes, but we will just talk about vascular thing. If there was no preceding illness, then we would have thought of many other vascular etiology, metabolic, hematological, etc. But because of that, I think we'll restrict to that. That's the best way to go by.
Tell us what investigations have you done?
We got a CBC done with hemoglobin of 9.4, total counts of 10,500, with poly of 40 and lymphos of 60%, platelets of 3,56,000. PT INRs in normal, PT of 13 seconds with a control of 16. And
Speak in the mic.
Normal PT INRs with got a lipid profile done, serum triglyceride levels of 279, serum cholesterol level of 168 and HDL of 11 milligram per deciliter. Got a COX workup done. MON2 is negative, ESR of 80 millimeters at the end of 1 hour, X-ray is within normal limits, and USG is not showing, USG abdo is not showing any significant lymphadenopathy. Got a CT brain done.
You've not done a CSF.
CSF done, sir. CSF is normal, 1 WBCs with 1 lympho, proteins of 23 milligram per deciliter, sugars of 68 with the corresponding RBCs of 72 milligram per.
Okay.
CT brain is suggesting of large right MCA territory, non-hemorrhagic subacute infarct with mass effect.
So what could be the
It could be a post-infectious stroke syndrome, since although the child is not having varicella angiopathy, is very well known if the child had history of chicken pox in the past 12 months, and this is recently called as transient cerebral arteriopathy of childhood, but it is basically an MRI based diagnosis. So we are waiting for the MRI with MR angiography to look for any focal stenosis, and that stenosis should resolve over the 6 months to call it as a TCA. So that can be one etiology, since the child is having a large MCA territory stroke. The sickling is negative, I think, so sickle cell disease is ruled out. This would be on a post-infectious stroke syndrome.
Sure. And can you quickly outline the management in 2 minutes, and then we go on to the next case?
So to manage a child of arterial ischemic stroke, you first of all look at neuroprotection, which is very important because the brain is already damaged. So what you want to do is you want to preserve the neurons which are not injured. There are various areas called as core, penumbra, as all of us have known. So you want to prevent the injury to those zones. So you have to maintain the temperature. The child has to be euthermic. You have to maintain the blood pressure at 50 percentile. Oxygen needs to be given only if the child is hypoxemic. Anticonvulsants are to be given if the child is actively seizing. And euglycemia has to be maintained because hyperglycemia leads damage to the brain. So neuroprotection and signs, management of raised ICT is the most important. Then second comes to antithrombotic therapy. So either there are anticoagulants, that is low molecular weight, heparin, warfarin, or there are antiplatelet agents. So according to the latest guidelines in the International Journal of Pediatrics, the anticoagulants such as low molecular weight, heparin are to be used for only certain conditions such as a congenital heart disease, cyanotic congenital heart disease, then cervical artery dissection, then prothrombotic disorders, and some cases of vasculitis. Whereas in other cases, other than this, you need to use an antiplatelet agent such as aspirin. So in this case, since the etiology is still not known, we would start the child on LMWH till the investigations are known. And once the investigation is done and we get the MRI with MRA, then we can start on antiplatelet agent and wait for the recanalization of the arteries.
Fine, thank you. Can we have the next presentation?
My patient Tejashwini Devar, 1 year 1 month old female child, first by birth order, born of non-consanguineous marriage, Christian by religion, residents of and hailing from Ahmednagar, brought by and informed by parents with complaint of cough since 1 month, fever on and off since 4 days. Patient was apparently alright 1 month back when she developed cough which was dry, non-spasmodic, not associated with post-tussive vomiting. According to mother, cough used to occur only when feeding the child, multiple episodes per day, which used to resolve on interruption of feeding. Cough has no postural or diurnal variation. Cough occasionally associated with breathlessness and increased respiratory rate noticed by parents, but never with bluish discoloration of body and sweating over forehead. Fever since 4 days, mild grade on and off, not associated with chills, responding to medications temporarily only to recur again. And child was active during febrile as well as interfebrile period. On inquiry, mother also complaining of child not gaining weight adequately since 6 months of age as compared to peers. And history of recurrent episodes of cough and breathlessness associated with mild fever since 3 months of age, for which 2 times at the age of 3 months and 5 months patient was shown to some private doctor, and which used to subside on oral medications alone, no hospitalization required. And cough was never associated with bluish discoloration of body in the past. History of 1 episode of bluish discoloration of lips and extremities 15 days back, noticed by parents while the baby was crying. It lasted for 5 minutes only and subsided by its own. Patient was never investigated for that. And there was no history of lethargy, refusal to feed, no history of vomiting, diarrhea, no history of seizures, altered sensorium, focal neurological deficits, no history of pedal edema or increased urine output. And there was no history of recurrent nebulizations or allergic contacts, no history of nasal regurgitation of food or fluids, no history of COX or COX contact. Birth history, mother is antenatally registered at government hospital, taken TT injections and supplements, and no significant drug history in mother during antenatal period. No history of GDM, hypertension, fever with rash or neck swelling in mother during antenatal period. And it was full-term vaginal delivery at the government hospital, birth weight 2.5 kg, baby immediately cried after birth and fed within first hour of birth. No history of cyanosis, jaundice or seizures in early neonatal period. Immunization, immunized till 3.5 months of age as per universal immunization schedule. Developmental history was all milestones was achieved appropriately as per age. Dietary history was exclusively breastfed till 6 months of age, and no top feeding or bottle feeding was done. Currently, diet is deficient in 100 kilocalorie and 30 gram of protein. Family history wise, she is the only child to 29 years old father and 23 years old mother, and there was no history of similar complaints in the family. There is a history of one spontaneous abortion at 3 months of gestational age 3 years back. Socio-economic history was they belong to lower middle socio-economic class as per modified Kupuswamy scale.
So, can you just summarize the brief sequence of events from birth? So, birth history apparently normal.
Birth history apparently normal, and developmental history wise patient has again developmental milestone as per A. But since 3 months, patient has developed recurrent episodes of respiratory infections and fever.
Don't say respiratory infections, because
infections in the form,
whether they are infections we will discuss. So recurrent episodes of, you said initially, cough and breathlessness.
Cough and breathlessness with mild fever only every time. During 2 times patient was taken to private doctor, but and taken oral medications only, which symptoms used to resolve on oral medications only. Patient was never investigated for that. And 15 days now the cough since 1 month is mother telling every time when she attempts to feed the child, patient coughs, and on brief interruption of feeding, cough subsides. But there is no sweating over forehead and no bluish discoloration of body. 15 days back, one episode of cyanosis in form of bluish discoloration of lips and extremities was there.
Okay. Let's start discussing. What are your thoughts? So first let's take cough and breathlessness starting at 3 months of age. So what are your thoughts on that? Cough, breathlessness, and he said mild fever. Come on. Who wants to discuss?
History of cough and breathlessness since the age of 3 months, but the child was never hospitalized per se, and child was not so ill that requires the hospitalization. So it's less likely some respiratory infection like pneumonia or anything. It's more fever in it's like a cardiac origin because the history of fever and recurrent infection. It's less like a respiratory.
Anybody else?
The breathlessness is a predominant symptoms that indicate it's a cardiac cause. In a respiratory case, cough will be both predominant symptoms and fever.
So, but both are predominant, no? Cough and breathlessness. So first tell me, are these infections? Because, we always tend to just make this comment every time we say history of recurrent respiratory infections. So tell me, how will you decide whether these are infections or not infections? Come on.
What is the hallmark of an infection?
Sir, high fever, or was the patient sick?
Significant fever in each episode. That would tell you that it's a infection each time.
So therefore, he is specifically made a point that fever has not been a prominent feature at all. So the first thing is that these are not infections. Okay. Now what else can it be? So, means cardiac respiratory you said, but what else can it be? In respiratory, what can it be? Where is the anatomy? Where could it come from? So repeated episodes of cough and breathlessness. Could it be hyperreactive airway disease? Can it start at 3 months in a severe child with a severe family history? So why is this not hyperreactive airway disease? Could it be aspiration? Yes or no?
Yes.
Why aspiration?
As he is telling, after feed it comes.
No, that after feed story is just now.
Since 1 month.
In this last 1 month cough, he's saying that it is as soon as the child starts feeding, the child starts coughing. We'll come to that. We are just now on those repeated episodes of cough and breathlessness from 3 months of age. Can that be aspiration?
Yes, sir, it can be.
Why? And then, if not, why not? So first tell me why. Why it can be aspiration?
Is there any history of repeated episodes of choking on feet?
No.
Then less likely aspiration.
In full term, completely normal delivery, it's less likely and on an exclusive breastfeed. So it's less likely to aspirate and other infection. It will be more favor in congenital heart disease and any respiratory tract abnormality.
One sec. Full-term normal delivery, fine, but full-term normal delivery can have structural abnormalities of the respiratory system. They can have gastroesophageal reflux disease. So we are talking in general whether these episodes can be aspiration or no. repeated episodes of aspiration. We're talking of that.
Rajesh brought out a point saying that was the child choking ever? Is that mandatory for aspirations? So that does not rule out aspiration happening. Yeah.
Yes.
For that also find out. Is it more at night that can indicate sir aspiration also?
Okay, why? Why
Like lying down position?
No, I don't think that is correct.
A 3-month, 4-month child is lying down all the time.
See, my simple point was that if the history is correct and if all these episodes are cough and breathlessness, when will a aspiration become breathless? An aspiration will cough, but when it will become breathless, if it goes to the stage of a chemical pneumonia, so to say. So are we talking of 5 pneumonias, 5 chemical pneumonias or 4 chemical pneumonias? So if every time there is breathlessness along with aspiration, along with cough, then it cannot be aspiration story, no? Okay? What else? What else can it be? How should you think? See, we are not only discussing what this case will be. This is a story which starts at 3 months with cough and breathlessness. So what else would you think and rule out or rule in? So you are talking of structural abnormalities of the respiratory tract. So how will you consider them or not consider them?
First thing like a structural abnormality like that's a tracheoesophageal fistula also, that's you already rule out. Other in congenital heart disease, increased pulmonary blood flow, that can be there.
Yeah, so this can be congenital heart disease with an increased pulmonary blood flow. They can have repeated episodes of cough and breathlessness. What else? Anything else, or you are sure this is congenital heart disease?
In absolutely normal child, I can guess only 2 types of, at 3 months of age, I can.
Okay. So what he is trying to say is that if you, especially when you have repeated episodes of cough and breathlessness, starting at 3 months and when it is afebrile, we have already discussed that infections are not there, then this origin is more likely to be cardiac than otherwise. Okay. Now, how about the present story of 1 month of cough on feeding? What does that mean? The story is that the child is coughing for last 1 month, increases if the child is being fed and stops if the child is not being fed. So that's very typically aspiration, no? Or no? What does that story mean to you? Yes? What does it mean to you?
Sir, on feeding it aggravates means...
Speak louder in the mic.
On feeding it aggravates means I think there is some aggravating factor for cough such as...
According to me, if the story is correct, it only means one thing: this child is breathless even at rest. He is extremely dyspneic or breathless, and that is why the moment the child makes an effort to feed, the child starts coughing. It can only mean that one thing and nothing else.
Dyspnea on exertion, yeah, manifesting.
Sometimes the upper respiratory irritation would mean receptors in the lower respiratory tract get irritated. It's not rare for a child who has a bad airway disease to start coughing moment he starts even eating. So to that extent, we are not sure what it really means that. But if a child is breathless, he would not cough only, but he would probably not be able to feed. So I would have got the history that there is a difficulty in feeding. On the other hand, if he is able to feed, which means there is no difficulty in feeding, but during or after feeding, he starts coughing. That's probably receptors on the lower airways get irritated with any irritation even in the upper airway. And to that extent, anytime you cough, you like to swallow a sip of water What does that do? It's only an upper airway pharyngeal, lubrication. How will that stop your lower airway? So you probably reduce any irritation from the upper airway, which would stimulate the receptors in the lower airway to make you cough. That's why the moment I start coughing, you get me a little water to take a sip. How can that help my lower airway cough? Okay, and I think that is all that I would mean that. So I'm not very sure whether that alone would be a point is made that if he's breathless also, he will start feeding, he will find difficulty in feeding and then end up coughing. In fact, crying, for example, many children cry and end up coughing. Ask a typical asthmatic child, he would cry and make up coughing. That may be exertion induced as well in a bronchospasm, but yes, to that extent, I think that history may not get us to any very close interpretation.
Rajesh, just one thing. You gave a story of recurrent respiratory tract involvement. Now it would fit in very nicely with a hyperreactive airway with frequent infections or whatever. But what is worrying is that those children don't have growth failure. This child has growth failure, and therefore I would think in terms of a cardiac problem which is complicating this issue.
Yeah, but Anand, I was about to bring that up. He has given a gross dietary inadequacy as well, right?
Yeah.
Yeah, so he's saying the child is not growing well. Acha, you're saying, but that dietary inadequacy may be because of difficulty in feeding because of his cardiac problem.
Agreed. So, but we'll have to keep in mind whether the dietary inadequacy is because of the illness.
Rajesh, the baby was exclusively breastfed for the first 6 months. Unless the mother is very malnourished and there are some major issues, he would have got his calories by then.
Yeah. Okay. So now we feel that this might be a cardiac story. How is the child between episodes? Child is fine. There's no breathlessness, nothing, right?
Yeah.
No tachypnea noticed by the parents.
No.
There's no increased precordial activity noticed by the parents.
No.
Right? Okay. So suppose this is a cardiac story, then what kind of a heart disease are you thinking of? Acyanotic or cyanotic? There's no history of cyanosis except for that one episode. So now how do you analyze that one episode of cyanosis? Just repeat what happened and let's analyze that.
So there was one episode of bluish discoloration of lips and extremities 15 days back, noticed by parents while the baby was crying, lasted for 5 minutes only and subsided by its own. Patient was never investigated for that.
Okay. So what do you think was this?
After crying?
Yeah.
Maybe breath holding spell.
Very good. So this was a breath holding spell. Everyone agrees? Yes or no?
Yes.
Okay. So how long does a breath holding spell last?
You need more information about the spell.
Absolutely. So Anand is saying we need more information.
So there is one episode only, breath holding spell.
No, that is fine, but even for that one episode we need more information. Please let's learn to take good histories and more detailed histories. So now let's try and differentiate a breath holding spell from what else is there in your mind? A cyanotic spell. Okay. So tell me what are the differences? Both can happen after crying. But
Sir,
what is
after consoling by the parents when crying stops, breath holding spells. When parents draw the attention of the child.
In a breath holding spell, parents cannot control the crying. That's why the breath holding spell occurs. So in both situations, crying cannot be controlled. What's the difference in the crying of a breath holding spell and crying of a TET spell?
Sir, at the height of crying, child holds his breath and then get cyanosed.
Very good. So in a breath holding spell, the child starts crying, and at the peak of the cry which is attained very fast. So in say 30 seconds or so, the child starts attaining the peak of the cry and holds the breath. Whereas what will happen in a TET spell, the child will cry for some time, and because of that continuous crying for some time, the spell may be precipitated. So these are very minor intricacies that you will have to ask to differentiate. At first glance it will look like a breath holding spell. And of course that 5 minutes is something which is again very loosely put by parents. But how long does a breath holding spell cry last? The cyanosis last? How long does it last? So again a few seconds. So as he rightly said, at the peak of the cry the child holds breath, becomes blue, and then within a few seconds either starts crying again so that the thing is restored, or may sort of drop off into a quiet phase, and or then the other type which is the pallor type, which we are not considering.
Just wanted to clarify the term peak of cry. Might tell you that peak of cry is the child is crying and is crying vigorously, goes into spell. Peak of cry means there is aphonia. Once he starts crying, there is no sound only. He starts crying, you can make that out only because you look at him and there is no sound coming at all, at which time holds the breath. And then he may become blue. Sometimes it can end in a convulsion also. One can have in a breath holding spell a short convulsion. But sequence and also trigger, there has to be a trigger. The child is denied something or he's asking for something, so there is a trigger in breath holding spell always. An initial cry, sound just doesn't come. And when the sound comes, the whole spell ends. While in a child who has got cyanotic heart disease, he keeps on crying every time the voice is heard. He keeps on crying aloud, and at the end of the cry, then he becomes blue.
Even the timing, sir. Usually the TET spells are when the child wakes up from sleep or something like that. Whereas a breath holding spell is usually seen in a child who's alert, who's playing, who's being denied something.
So, we're coming back to what kind of a heart disease are we thinking of? Acyanotic or cyanotic? So tell me points which are in favor of acyanotic, points which are against acyanotic. Come on. It's very simple and logical, no? Which acyanotic are we thinking of? Commonest? VSD. Child became symptomatic first at what age?
3 months.
3 months. So if a VSD has become symptomatic at 3 months, what is the size of the VSD? Sorry? Moderate to large. There have been many episodes. So what else do you expect which is missing here in the history? Those are the atypical points or the odd points. So what is your classical story of a VSD? What else is there in the history?
Sir, in VSD there is suck-rest-suck cycle, sir.
Okay. Suck-rest-suck cycle, perspiration of a forehead. What else? Once this child has had 2-3 such episodes, often you get a history that this child is breathless all the time. Means inter-illness this child is tachypnic or breathless. Many of these parents do notice increased precordial activity. Some of these are associated with fever, those episodes, because they end up with, because of increased vascularity, they end up with some infections. So these are some points which apparently are not there in the history, plus that one episode of cyanosis, whatever it was. What about cyanotic? There is no history of cyanosis noticed by them. So do you still consider a cyanotic heart disease? Parents have not noticed any cyanosis.
Cyanotic heart disease with increased pulmonary blood flow can be possibility because they have very minimal cyanosis.
Very good.
Parents can be miss that.
Very good. So one possibility is cyanotic heart disease with increased pulmonary blood flow, where the cyanosis is not very prominent and there will be symptoms of failure like this cough and breathlessness. So that is possible. What else? But in those children, will you get a hypercyanotic spell? If we were to believe that that one episode was a hypercyanotic spell. Vigorously nodding head, no. Why? You're right. You're right. So why?
We get cyanotic spell when the pulmonary blood flow is decreased. We are considering the cyanotic heart disease with increased pulmonary
Very
blood
good.
flow.
So all those spells are seen in basic conditions where there is decreased cyanosis with decreased pulmonary blood flow. So if we are basically talking of increased pulmonary blood flow, then that should not have occurred.
On a lighter note, Rajesh, in his history he mentioned at least 5 times that there was no history of cyanosis. So I strongly suspect a cyanotic heart disease.
Correct.
Though I agree, Dr. Rajesh, that the history doesn't gel well. With recurrent respiratory infections, you say expect a plethoric lung field, and with a cyanotic spell, you should have a pulmonary alingema. Any child with heart disease, any cyanotic spell or something similar to cyanosis makes it is cyanotic heart disease. Let your history be there, otherwise. So he had some cyanosis somewhere, a cyanotic, though it may not be typical cyanosis spell. A cyanotic heart disease has no business to develop cyanosis. And a cyanotic heart disease will always be acyanotic, superficially evaluated.
Sir,
So
I was
just
trying to say the other way around, that though he kept on saying that there is no cyanosis, so it looked like a acyanotic heart disease, but I was pointing out that there are so many things which are not there, so it may not be really acyanotic. Okay, let's examine the child. Who wants to volunteer examination? Some new volunteers this time. Please come ahead. This is the best way to learn.
Best way to pass in the first attempt. Nobody wants to pass in the first attempt.
Anybody wants to try examination? Very good. Come. आप इधर आ जाइए.
She's sitting comfortably on the mother's lap. Her look, she's anxious. She's comfortable. There is no tachypnea, and she's playful, trying to interact, and she's looking around, and as such, on head to, she's mild nutrition wise, she's malnourished, moderately malnourished, and on head to toe examination, first of all, looking at her hairs, sparse hairs, brownish thin, and frontal bossing is present, and depressed nasal bridge, and she looks pale, and
Okay, so now let's learn a few things. So when you talk of, when on inspection you are commenting on nutrition, what all are you looking at?
the build,
Okay, so the build of the child, the The height,
Height.
the weight,
Weight and height.
and so means don't forget to look at presence or absence of subcutaneous fat, visible wasting, because height and weight is often has a genetic element to it. Okay, so don't go strictly by the height and weight. So look at other things also. So if there is not too much of wasting, then don't upfront say that there is moderate or severe undernutrition. Similarly, the hair. Now, when we say sparse hair, brown hair, what are we trying to imply?
Malnourished.
Protein malnutrition of some standing. Okay. Now, this is a young baby. So, we must check whether this is the kind of hair right from the beginning. And if so, then it doesn't imply all that we are trying to say. So, what we are trying to say is change from originally normal to this. So, which if may not have happened. Okay. Yeah. What else? So, when you are looking at inspection in a possibly a cardiac disease child, what else would you like to look at?
Tachypnea, cyanosis.
Yeah, tachypnea you mentioned, cyanosis, then dysmorphism, any other? Huh?
Yes, sir.
So dysmorphism, any other congenital abnormalities? Okay. Fine. Now go ahead and examine. I'll hold that for you.
Especially heart and fingers. Congenital abnormal, apart from face, we have a hand-heart syndrome. So concentrate on fingers and upper extremities.
Sir, I feel the fingers are a bit longer, and I feel the cyanosis is present. Tips of the nails, especially.
So how will you confirm?
Oral mucosa.
Very good.
Sorry. So the tongue looks pink, and only I feel now peripheral cyanosis. There's no central cyanosis.
So can this girl have peripheral cyanosis? Should this girl have peripheral cyanosis? So in other words, I am asking you, in what situations will you see peripheral cyanosis? So is she in circulatory insufficiency?
No.
Why not? How can you be sure?
Anemia can...
No, first, you're right, she is not in circulatory insufficiency. Why?
No central cyanosis.
No, she is looking so normal, no? So, and plus then you can feel her pulse and find out that she is not in circulatory insufficiency. So, there cannot be peripheral cyanosis due to that. Is it too cold around here?
Yes, for her it may.
Okay. What I was trying to tell you is that I don't think there are enough situations just now to explain peripheral cyanosis in her. So even if you can't make out on the tongue right now, if you can make out on the nails, then it's reason enough for you to suspect central cyanosis and confirm it, whatever way you can. Okay, go on. You want to examine the CVS?
Yes, sir.
You want to make her lie down or उधर सुलाएंगे तो रोएगी नहीं तो सुलाओ इधर सुलाओ quickly examine.
On inspection, the there are bilateral intercostal retraction and intercostal retraction as well bilaterally, and ये नहीं निकाल लेंगे।
ठीक है,
रहने दो, रहने दो।
I think just quickly examine completely and then tell us what your findings are. I think we are running late, so
there is no increased precaudal activity. Apex beat inspection in the mid-clavicular, just medial to the mid-clavicular line, and on palpation also apex beat is in the fifth medial to mid-clavicular line. Percussion I won't be doing, and no other pulsation seen, not even in the epigastric or P2 area, no other pulsations. And auscultation. In the mitral area, on auscultation in the mitral area, there is a systolic murmur and without a thrill, so grade 4 and grade 3, sorry, and in the tricuspid area there is no murmur, and in the pulmonary area the S2 is loud, sir. And in the axillary also the same murmur is there, and she was crying in between. There is crepitations in bilateral lower zone of the lungs also, and it was a sort of continuous murmur only which I heard.
what are your findings?
On
अब बैठ जाओ या ले लो.
On inspection, precordial bulge is seen, sir. Apical impulse is not seen. And on palpation, there is a trachea. On palpation, trachea is in midline, as in inspection. Left parasternal heave is present, and left parasternal thrill in left third to fourth intercostal area is present. Left parasternal heave and left thrill is left parasternal area is there in base felt in left third to fourth intercostal area.
Go on.
An apical beat is ill sustained and diffuse, but base felt in left fifth intercostal space, slightly lateral to mid clavicle line. So, and
go on.
On auscultation, there is a Grade 4 harsh blowing murmur, best heard in mitral area, and in pulmonary area there is P2, second heart sound is loud.
So what
in
does
breast areas S1 S2 is not.
So what does each of your finding mean? So apex beat outside the mid-clavicular line means what?
Means cardiomegaly is
Okay.
there.
Then?
And then left parasternal heave. So left parasternal heave there may be a right ventricular and left atrial hypertrophy is there.
Okay.
And then thrill, the murmur intensity is high. That means there is a large defect.
Where is the thrill?
Thrill is in left third to fourth in best field in left third to fourth intercostal area.
Okay.
And
so what is the significance of a thrill?
Thrill means there is a forceful murmur. So
Origin of murmur, that's anatomical defect lies below the thrill.
So the anatomical area in which you feel the thrill, the defect lies in that anatomical area. Whereas murmur can be conducted, radiated, whatever. But if a thrill is at a particular place, defect lies there. Okay, go on. Then?
And then there is pulmonary loud P2 in loud second heart sound in pulmonary area. That means there is a pulmonary hypertension present.
Okay. So what is your final diagnosis? Yeah,
That is looks like a case of congenital cyanotic heart disease with cardiomegaly, with pulmonary hypertension, with not with overt sign of failure. To rule out total anomalous pulmonary venous connection and truncus arteriosus and transposition of great arteries and all.
And did you say there was cyanosis?
So one episode was there, and we can't say that there is we have not enough reason to say that is a cyanotic heart disease there.
No. Clinically, did you say there was cyanosis?
No, sir. Not one.
Well, I think we are getting late, so I'll quickly, I think there's obvious cyanosis, as this girl said, that the nails are blue, and I don't think there's any reason why this child should have peripheral cyanosis. In the presence of cyanosis, Khare sir already mentioned that you cannot talk of any acyanotic heart which has become cyanotic in such a short span of time, 1 year, and the child, it is not Eisenmengerization. So I think we didn't have time to examine the child, but we will have to seriously question all the findings and their correlation. You have nicely presented it as a left to right shunt with pulmonary hypertension, but I doubt that story. Sir?
I think the first thing in the clinical analysis is when has the cyanosis come up. This child's cyanosis has come up at 3 months of age. And I think that almost reduces your chances of what kind of defects.
Cyanosis didn't come up at 3 months. In fact,
observed.
No, nobody has seen cyanosis.
Okay, so on examination. So which means that if this is cyanosis, it did not present early. Okay. That means 2 types of lesions which come up with cyanosis early are all ruled out. One is a common channel. You may have a truncal single ventricle, etc. Or one is a parallel circulation with a good pulmonary circulation. So those are all out. Another thing is that this child is probably tachypnic. So this child is failing. So another point to make is that though we haven't reported cyanosis, we said that this is unlike a left to right shunt basically. Left to right shunt would have been much more severe, manifesting at 3 months would have been a large VST. and a large VSD would have been very symptomatic. Whereas this child has pulled on for a year, to that extent it did not fit in a left to right shunt. In which case we came on to say that there was some cyanosis observed or whatever, and therefore we are talking about a cyanotic heart. To me, if therefore a cyanosis was not evident to begin with, or not reported, seen only later, in which case a large chunk of those children who come out with cyanosis early are all ruled out. Which are those conditions which come up a little later, largely an oligemic lung types of thing. Now you may have a variation of oligemic lung thing. Okay, Fallow's is just one typical thing, but a DORV is another variant, and a transposition is another third variant with a pulmonary stenosis. And depending on what the pulmonary circulation is, your cyanosis will come up a little later. So one would have thought on examination that, but there was a history of cough off and on. Now that was something funny. Those conditions will not have a cough. So I think here we are getting mixed up. If you saw cyanosis, definitely then the whole story doesn't look like. But if there was no cyanosis, then of course the left to right shunt of what kind we don't know. So I think what next time we would have is that at least people who are around here must examine and then tell us what exactly the findings are. In a short time like this, we are not sure what we are dealing with, and we are left with just the investigations to talk of. Findings suggested left to right shunt, but cyanosis suggested it cannot be just like that. So I'm not sure really where we stand with what you said to me, right?
What's the final diagnosis, and tell us if any investigations have been done.
Sir, we will start with X-ray, echo.
Speak in the mic.
In echo, it is intracardiac TAPVC non-obstructive type with large OSASD with obligatory right to left shunt and with dilated right atrium and right ventricle and severe PAH with normal biventricular function.
So it is a TAPVC which is unobstructed, right?
Yeah.
Non-obstructed TAPVC, so which explains the signs of failure that we have got, and because it is a TAPVC, it is a cyanotic heart disease. So this comes in the category which one of them mentioned earlier, that cyanotic heart disease with increased pulmonary blood flow. That's why mild cyanosis with failure, this is the category that this comes into, right?
Yeah.
Yeah. Okay, fine. I think we'll stop here because I think they want to.
Thank you. We come to the end of today's telecast. The next telecast will be from Kanchi Kamakoti Child Trust Hospital, Chennai, on 11th of March, Wednesday at 2:30 p.m. Thank you.